Hello, I'm Ushma Neal with the Journal of Clinical Investigation and would like to welcome you to the next in our series of conversations with giants in medicine. Today, I'm delighted to be speaking with John T. Potts Jr. of Massachusetts General Hospital and Harvard Medical School. Much of our current understanding of calcium metabolism rests on a large part of a series of discoveries made by Potts. He is an internationally recognized authority on calcium metabolism and the hormonal mechanisms that regulate it. In particular, Potts has been a pioneer in the chemistry and biology of parathyroid hormone and in the clinical disorders that are associated with its dysregulation. In addition to these research findings, he's also carried an enormous leadership role as serving as both chairman of medicine and physician-in-chief of the MGH between 1981 and 1996. Welcome, and thank you very much for joining us today. I'd love to start by finding out a little bit about where you grew up and your parents.
Yes, I grew up in a small town in New Jersey, Moorestown, New Jersey, which was sort of in the suburbs of Philadelphia. And I went to school at LaSalle College High School, and then the high school, and then the University of Pennsylvania for medical school. And wanted to head north to the great MGH, and fortunately got there.
Well, how about your parents? Did they have much of an impact on you and your choices?
Yes, my father was a florist and a very active one, and his father also. I was very fond of my maternal and paternal grandparents, and my mother was the one who had the vision that maybe I would become a physician. And I didn't have a very, you might say, focused career ambition. It just seemed like a nice idea. I knew some nice doctors. Oh, that's a good direction to go in. And this gradually went ahead in that direction. And then I went to medical school at Penn, and the rest of it is sort of history, as it were.
So did you excel at science during your early years? Was there ever something that made you think, I want to go to medical school?
Oh, I wanted to go to medical school in other words, you have to do something when you grow up, and I was always focused on being a physician. I didn't quite know what it meant, really, but I knew what it meant for the practitioners that I knew in our community. And so I guess when I was starting medical school, I thought I might go into general practice and return to the Moorestown area, which I'm sure was my mother's dream. But as I went in through medical school, and particularly in the third year, when I began to see patients on the medical service, I became very interested in what's behind the diseases we see, and if we knew more, could we do a better job? And then I decided to become interested in science. So I really never did any previously. During the early part of medical school, I had a great teacher at LaSalle College I sort of had a minor in English literature. I used to go back to his house for seminars in modern fiction and so on. So I didn't really get serious about my studies at Penn. When I finally got this impulse to want to go to the MGH, which was then sort of the hot spot, or as it were, I thought, well, you've goofed off, but turned out I hadn't done all that badly after all, and they took me.
So what made you think endocrinology and bone biology and mineral biology?
The part of the story, when I was interested in what's going on in the pathophysiology of patients, what's behind the mechanisms of the poor diseased person we see, one of the things that I noticed was endocrine homeostasis. And in particular, what caught my eye, at random I suppose, was parathyroid hormone and its like the sensitive thermostat for minute-to-minute regulation of calcium. I thought, what an interesting system. That might be a place to learn a little more. I wasn't sure of that, but that was my thought. And then there was a wonderful surgeon named Brooke Roberts, who was a parathyroid surgeon, among other things. And I worked with him through several, as the study, and we actually wrote a paper together about a disorder of magnesium metabolism in a person with tetany. We got the mechanism wrong, but we were interested in it nonetheless. And so we published a little paper, 1958, I think. And then I went to the MGH, which was, of course, the center of research in this area, as in many others. And the great Fuller Albright, who had just been incapacitated by a stroke a few months before I arrived as an intern, and Oliver Cope, who was a famous figure. In other words, there was a concentration of people interested in metabolic disease, and in particular, calcium disorders. You may know that the first patient successfully diagnosed and operated on for hyperparathyroidism was at the Mass General in the United States. There was a case earlier in Vienna, but it reinforced it very much. I found myself in an environment that was very stimulating. The chief at that time was a remarkable man who's been celebrated by one of your earlier interviewees, Holly Smith, in a marvelous article. He was an inspiration and loved to find people that he thought had talent. And I don't think he thought of me having much very talent. I just revered him. But he, you know, were very interesting things, and I don't want to spend too much time on that. But anyway, what was interesting was that he would pick people at the MGH then who had, he felt, some spark or some talent, and he would make them heads of areas of subdivisions of medicine, gastroenterology, endocrinology, even though they had no training. A lot of what we now think of as the long route to specialty training didn't exist then. And so his famous saying was, okay, Isselbacher, you can be chief of gastroenterology. I'll give you 5 years to do it well. If you don't, I'll kick your ass out of here. And that was his formula for each of the people that he had. But I left. He was very ill at the time that I was there. He had chronic lung disease. Well, that was time to decide what to do next. And there was the opportunity of going to the NIH. The role, I've spent altogether about 56 years at the MGH and Harvard Medical School, but only 48 of them continuously because I had an opportunity to spend 8 great years at the NIH. And that was the time of the doctor draft, which most of us didn't understand anything about. What I wanted was to go to the NIH because that's where you could learn to do science seriously.
So this is when you really ground your interest in doing research.
That's right. It began in medical school, was reinforced by my time at the MGH, filled with people who were models of how to do investigation, and they were inspiring to me. And I thought, well, maybe I'll try to do a little something as they have done. So getting to the NIH was wonderful, and then I brought back this interest in parathyroid hormone, a rather humble molecule at that point. It was one of the last hormones of the classic type to be recognized, and it doesn't even have its own name. You realize, parathyroid. It's named by the gland it's next to. But it was clear that it played an important role in homeostasis of calcium and was involved, we already knew, too much of it caused disease. So I decided to go to Chris Anfinson in the NIH, a wonderful man who later won the Nobel Prize, despite people like me wandering through his place. And I learned how to do protein chemistry. And then there was a man called Gerald Auerbach, who was a great friend and a real pioneer in the field, who had just, before coming to the NIH in the Astwood Laboratory, made a great breakthrough with parathyroid hormone, isolating it in a form that didn't produce it in pieces. So you had a chance to isolate it. So I had the protein chemistry, he had the biology. We teamed up across 2 different institutes and worked together for over a decade, a time that continued after I went back to the MGH. And we had a lot of good time then.
Well, certainly. Your third publication in 1963 is together with Burson and Yalow,
yes.
some people who are sort of larger than life in developing
absolutely were.
A radioimmunoassay, and in your case, it was the radioimmunoassay for parathyroid hormone. So what was it like working with them?
Well, I admired them, particularly Burson. He was a remarkable man, driven, brilliant, fine in mathematics. He used to play multiple chess games with, play several people at once. And they developed this concept of the radioimmunoassay, and then they went after each of the endocrine hormones that would work with people like us who'd isolated this one. So we learned a lot from them, and that we then developed the first assay. Now, in retrospect, it wasn't very good for diagnosis because there was a lot of false positives. Nonetheless, it was wonderful, and we were then able to use that method to study the secretion of the hormone, which had never been done. Once you could measure it directly in the blood, you could find out what things regulated it and what the nature of the regulation was. So we did work in sheep and cows and goats and so forth with people that began to come to the lab. The NIH allowed me to stay on and have my own independent lab. So Auerbach and I worked together and we had a great time.
So you went on to find the complete amino acid sequence of bovine PTH, which...
Yes, that was a very challenging operation. I remember colleagues of mine who'd come from different places to the NIH. They thought I was clearly crazy to work on a project of that magnitude. And of course, that was when protein structures were just being worked out. Sanger had done insulin, which was plentiful in the pancreas of cows. Parathyroid hormone, a little gland, and it was very laborious to purify it. But we did finally do it and stayed with it and were able to work out the structure slowly, finally finishing up completely in 1971, I think, after I'd gone back to the MGH.
Right.
The methods that I think you know were rather laborious compared to the great skills of molecular biology today, where you can deduce the structure of something through the genome information without ever actually isolating it. We didn't have that then. Molecular biology didn't come into full flower until the middle of the 70s. So I had to do it the old-fashioned way.
You also took on the isolation and characterization of calcitonin, which has opposing effects to
Yes.
PTH.
Well, it was obviously interesting. Some people approached us because by then we had a reputation for being able to do protein structure, and it seemed to us to be, you know, the yin and yang of the story. Might as well work at it, and we got good quantities of material. We worked with wonderful people in the field, classic endocrinologists Paul Munson and Harold Kopp, respectively, and so we did that. Now, it turns out that calcitonin probably isn't very important in human physiology, at least if it is, we've all missed it, because people who lose calcitonin by total thyroidectomy, it's a thyroid locus that the gland is in. It normally comes from a different gland, the ultimobranchial body, which fuses with the thyroid. But we had fun with it, and it's medically useful, and it was used in the therapy of Paget's disease, and we had a good time with it. But we went back to our work on parathyroid hormone pretty earnestly, because that one we knew was biologically important.
Well, I mean, over the course of the years, you isolated porcine, bovine, ovine, and salmon calcitonin.
Yes.
And salmon calcitonin was one of the first therapies for Paget's disease,
That's right.
right?
It was, yes. It was the only thing at the beginning, yes, yeah, right.
So after these 9 years at the NIH that were very productive, although it sounds like they were very labor intensive, you landed back at MGH as head of the endocrine system. And then, as you mentioned, you then spent the rest of your career there. What was it like in the early days when you went back?
Well, it was still the pattern that was started by Bauer. In other words, I never had any training in endocrinology at all. So I was recruited back to be the chief of endocrinology. So it was because of my work in parathyroid hormone and calcium biology. And it was much as it is today, but it was just everything was simpler. The place was smaller. Everyone knew one another. The techniques were not of the great magnitude that we have today, interactive. You know, it was still more of a solo operation. People came back with me from the NIH. We had a great time there. It was wonderful. But it was the scope, the pace was smaller, but the principles were pretty much the same, I think. You know, today you have the Broad Institute and the Reagan Institute and these marvelous, very spectacular examples of technology applied to the cure of AIDS in the case of Reagan, or to genomic sequencing in the case of the Broad, where philanthropy has made a huge difference and great centers have arisen. That's all was very different in the beginning. When I was there in this, early 60s and late 60s rather, and early 70s, it was much more of a one-by-one approach. Same principles, slower pace.
In 1981, you moved up to take on the role of chairman of medicine and then
Yes.
later physician-in-chief of MGH as well. So how did you balance that administrative and leadership role with also a very rigorous laboratory regime as well?
Well, I was fortunate. I wanted to stay with it. I had wonderful colleagues who had grown up with me in the endocrine unit between 68 and 81, and they seemed to tolerate and want my presence. So I just blocked out time as chief of medicine. 3 or 4 days a week, I would just leave the office and go with the research group. And since we were very interactive, I wasn't directing a postdoctoral fellow. I was working with my senior colleagues, and we would be sharing information. Pretty much the system that I started when I was chief of endocrine. We'd have 3 or 4 what we call work conferences a week, in which people would present what's going on. They'd look at the challenges. Where should we go next? What's wrong with this? How should we go? So that allowed me to do that. And many chairs of medicine had national duties. You know, they would be on administrative boards, the board of internal, and I sort of made the deliberate decision to not do as much in that area and instead protect my research time. And that was very fortunate for me, because when I finished, I could resume it. and always stay with it. Well, that was very lucky. It was partly my personality, the personality of the people I was working with, and certain deliberate decisions.
Well, over the course of that 15 years, how do you think that the culture at MGH changed? What are you most proud of changing there?
I don't know that I changed anything. I maybe emphasized certain things. One of the things that I did do, which I'm rather pleased about, was underrepresented minorities who are not as prevalent in the hospital as they should have been as the population. And so I realized that I was chief of medicine, I could do some things, and so I started an effort at bringing in underrepresented minorities. We recruited them and tried to particularly protect their career development. And that later, after I was chief, grew into a center at the MGH called the Office of Minority Professions. So that was important, and I still have many friends from those days. I learned a lot about the issues for underrepresented minorities through getting close to them and getting to know them, both men and women. And that was one big thing. I think the second thing is you have to watch the people in your department and get to know them a little bit as best you can. And retention of great people is very important. You can't keep them all, you don't expect to. But when somebody gets recruited, my philosophy was you don't wait until you find out what their job offer is, you go after them right away. Even advise them as individuals how to look at the job they're looking at, but be very avuncular with them at the same time. It makes a huge difference if they know you care about whether you stay or not. So I was proud about that. The other thing, having had a good time as a physician scientist, I spent a lot of time, I formed a little group called the MGH Society of Research Fellows. And there's some 60-odd people, 60-odd members altogether. And I would help them to find good laboratories to go to. Often they would be here for several years, then they want to go into some basic lab. And I had good connections with people at MIT and Harvard, and I would call them and say, you know, so-and-so is a very bright young guy, and you should give him a chance in your lab. And we even had, under the former NIH director, Jim Weingarten, there was a period when there was a physician scientist training grants. We had the longest run of that, and so we could support them, which was also important. But, you know, the main thing was knocking on the door.
So same question, but with regard to your research. What do you think was one of your favorite projects that you did?
Well, I think it's the translational opportunities. So we realized that the radioimmunoassay that we've developed with Burston and Yalow was not as good as it could be, and it wasn't really very helpful in making a definitive separation of patients with mild hyperparathyroidism from normal. And there was a man in England called Roger Eakins who emphasized that you should use the assay differently. They should use two antibodies as a sandwich and the hormone in between, and one to capture the material and the other to detect it. It was radio-labeled. Those assays had much higher sensitivity and specificity, and so we developed the first one that was clinically useful, working with a pharmaceutical group, or not a pharmaceutical, a biotechnology group that was interested in developing radioimmunoassays. And then we really could use it as a good tool. So that was one thing. The second thing I think was most exciting was to listen. We had a very fine pharmacologist from England who died tragically quite young, John Parsons. And he had resurrected an old observation of Albright and Bauer that I mentioned before, the great leaders of an earlier time in the MGH, who had published a paper saying if you gave parathyroid hormone to rats, their bones got stronger. Didn't make any sense, but they published the work. He said if we do this properly, maybe we can help osteoporosis. So we began with Robert Neer in the endocrine unit, who was then a young fellow. We began our research in that area, which many years later led to the drug Forteo. And we were very excited to see that it could help with osteoporosis. But I liked doing the basic work as well. I liked cloning the receptor and understanding somewhat more deeply with time how this hormone works. We really don't know very much about it yet, but we are learning all the time. The complexity of this is very interesting.
Have we gotten anywhere in understanding why pulsatile PTH is anabolic while, constant infusion is catabolic?
Well, it's a very thoughtful question. It means you've looked into the issues a bit. It remains a mystery. It's very clear that that is the picture. That is to say, that short bursts are anabolic and longer exposure is catabolic. Now, what parathyroid hormone exists for, primarily, and is its ultimate role, is to protect the blood calcium level at the expense of the bone. So what's happening is this is a pharmacologic trick that a short exposure activates the osteoblast, which is the bone-forming cell, which is what parathyroid hormone uses to activate the bone-resorbing cells. But that phase is a little slower. So you sort of get in and get out again, hit and run is what happens. And you'd think we'd know more about it by now. And there are many, many theories, many bits of data. But the fact remains that a short exposure, perhaps because of the cell biology of bone, makes the result you want. And this was the issue that John Parsons, that I mentioned, had picked up on. And seeing these injections in rats building bone. So when we started, it was a very difficult area because the techniques for non-invasive measurement of bone mass were not present. Mm-hmm. And Robert Neer, who worked with Parsons and me, was the one who did a lot of slogging work, tried to do calcium balance, which is odious, meaning you recover, it's even odorous, you recover feces and measure the calcium and that. But the main thing was they did bone biopsies. But of course, subsequently, non-invasive methods, which in the bone fields came along to measure bone mass. And then it was much easier to see that it was really building bone. Then many years later, 2001, I think, the seminal paper with Neer as the first author, an international consortium, came out. And then the drug was nearly killed because some ill-advised toxicology was done by the company that was the sponsor, and they poured it into a cancer-prone rat strain and caused osteosarcomas near the end of the lifetime of the little Fisher rats. And that leads to a black box warning. But everyone realizes now that that's got very little to do with the human situation, and so that it's not relevant. But it was a problem for the FDA. I went to the FDA meetings. We weren't sure whether they would approve it or not. But the efficacy was so strong in the trials by that time with the non-invasive methods of measurement that they could see it was going to make a difference.
Well, as you were saying off camera beforehand, science is quite circuitous, and it takes a lot of different approaches to get to the ends.
For young people that we want to encourage to stay in this marvelous field despite all the stresses and strains, opportunity and prospects for growth could never have been greater, and that in the numerator over very poor resource allocation, a very unwise decision by the government, despite the best efforts. Francis Collins spoke about this yesterday at this meeting. There is opportunity for people, and we have to find ways of stabilizing and encouraging the younger people and let them know that they don't have to, the way careers develop, looked at in retrospect, seem very linear and straightforward, and how could anyone decide that that's what they were going to do? Well, that's baloney. They don't. They're just trying to work hard, and they make some progress, and then they see an opportunity to go in a different direction. So it's a sort of erratic, step-by-step movement. And it looks very clear in the end, but not when you're doing it. And that's important for young people to understand. Just work hard and pick a good problem and get some good help from people around you. Don't be afraid to share data, and you'll get somewhere.
So is that how you felt when you were going through it? Because in looking at your CV, it's quite a linear trajectory of, picking off problem after problem, whether it was calcitonin or PTH or mechanisms of action of PTH and various things within calcium metabolism.
Well, once we were working in the field, it was clear where the next question in that field might be. But why did I work on parathyroid hormone as compared to something else? Why did I become a physician scientist instead of something else? Those are things that are much more complex. But what I meant was, you know what the question is you want to answer next, but that's logical. But I mean, you want to avoid giving young people the idea that they have to see a clear path from where they are to where they're going to be 40 years from now. It's not as simple as that. And being opportunistic, hardworking, and collaborative are the key things to get where you want to be. I had collaborators my entire career who were wonderful. I was a player on the scene, occasionally conducting the orchestra, but they were, many wonderful people came to work with me. And I suppose the personality of the leader is important. I mean, if you celebrate young people around you, they feel like they can grow, then they like being around you, and you like being around them. And that's also important. Sort of a rigid, controlling approach doesn't build collaborative networks. And those are critical, particularly in today's science. You have to be interactive and supportive. MGH is like that. People celebrate one another's excellence rather than being threatened by it, I think.
Speaking of looking through your CV, I noted one thing that jumped out at me as sounding like it must have been entertaining. In 1980, you were on the US-USSR Joint Working Group on Space Medicine.
Yes.
So what did that entail?
Well, I'll be very frank. I think it's perfectly clear I'm perfectly all right now to discuss it. At the time, the Russians had claimed they had solved the problem of weight loss in space, but they wouldn't tell us what it was. They wouldn't tell NASA. So NASA wanted to bring a scientist from the U.S. who was sort of well thought of already by that time as a sort of bait to get the Russians to talk. And that's why I was brought along. I had briefings from the State Department, how I was to comport myself. There were people who wanted me to smuggle things in for the refuseniks. I said, I don't think that's a very good idea, this particular trip, which is under very high scrutiny. And then we were in Russia, we had a wonderful time, but it was a dual opportunity, a dual experience. Our hosts were wonderful and genial, but in the background was the KBG trying to embarrass the delegates. And there were some harrowing experiences. I don't know whether we should get into them or not, but they were quite, the schizophrenic aspect of the Russian society was very evident. They were trying to trap us into doing awkward, stupid things and involve beautiful women showing up and jumping in our lap and so on. And we were very noble and went straight ahead, didn't get distracted. And there was a wonderful Russian U.S. citizen who was with us. I won't mention his name. I don't even know if he's around anymore. But he said, don't let these people pull this off. Don't let, and the head of the delegation ran away from the table when these people came. He said, don't let them do that. You go and tell them to come back. We'll handle this fine. And then he would insult the Russians in Russian. And they had television monitors in every room. So it was sort of a sick society, but we got through it fine. And we learned the answer. The answer was there was no secret to find. They had poor measurement techniques. So they did measurements before and after the flight, and the error was such that you could make no conclusions. There was no secret. In fact, we have not solved the problem of reversing weight loss in space today. If we went to Mars, we would have people with advanced osteoporosis who would come back. We may be able to use medical therapies. I haven't stayed much with NASA since those days, but it's still a problem. But I wouldn't have exchanged that experience for anything. It was really remarkable. Then we also went to the Bolshoi and had private tours of the Kremlin art treasures. That was done by our host. So it was a very nice experience, but it was certainly bizarre in its range of activity.
So speaking of different kinds of research, in 1995 you moved from your position as chairman of medicine and physician-in-chief, or was it 1996, to director of research for MGH?
Well, that was a position that was created for me by the then chief of the hospital, or the president of the hospital. And it was time for me to step down. I'd been there 15 years. I was almost 65. And, you acquire barnacles after a period of time, in the journey. It's time for new blood. And that happens all the time. So it was good for me to change then. But he liked my work with young people and my eye for bringing along people that have scientific ability. And so that's why he created this position for me. And I did it. I do that informally now, but I didn't continue in that role formally for more than 3 or 4 or 5 years. But I still do it informally quite a bit.
Well, in that regard, you must deal with a lot of people's problems, or at least you did.
I do, yes.
So what's the range of things that people have brought to you? Family issues?
Yes.
HR issues in terms of dealing with their bosses?
Yes. All of the above. With my young scientists, when I had the physician scientist training grant, occasionally they would be in the lab of a person I would call an anti-mentor, and I would arrange for them to go to a different lab. But listening to people, being an advisor can be for your just listening carefully, making sure what they want to do, and then try to offer some support or make some connections for them, and then be sure to follow up. It's all of them. What mentoring is all about is the role of the person you advise, 99% of the time. But I did discover, as I might say tomorrow in connection with the Cobra Award, that when you see the letters that people write in connection with awards and so on, I've received a few of those in the mentoring area, the poignant comments that they make about what it meant to them at a certain moment in their life means that it's probably more important than we realize to be active as a mentor. And therefore, we should always be receptive, and I want to urge my colleagues to continue to do that. Right now, the stress is high. We're going to lose people who leave the field. And if we are receptive and encourage them, we won't lose so many. And I think that's very important.
Did you ever have psychiatry and psychology training? Because it certainly sounds like it.
No, I never did. I admire psychiatrists. I have many psychiatrists who are friends. But, it's your personality, I guess.
It's a more humanistic approach to...
Oh, yes. I've always enjoyed that. The late Lewis Thomas said the only preparation for medicine should be Greek, meaning that you should have a cultured education rather than a ferocious science background. The interest in people is, after all, what medicine is about. Now, science becomes more abstract, but for physicians, an interest in the person is central. Our modern society demands greater throughput from physicians, and they're on their computer board when they're talking to the patient. And I always felt that you have to connect with the person directly. I think that was instinctive. You don't let the phone ring, you don't do anything when you're talking to that person. You want them to know if they're your patient or it's someone you're mentoring, that you're focused on them. What they need is what you're interested in, not some other aspect of your life at the time. I think that's the personal issue is very important, I think.
So in that vein, do you recall that there was ever a particular patient that stayed with you all these years that you learned something from that interaction, or that shaped the way that you approached your science?
Well, I can't say that directly, but I do remember being very inspired. Fuller Albright had worked out a very strange disease called pseudo-hypoparathyroidism, and then defined a related form called pseudo-hypoparathyroidism. Now, of course, he had a great sense of humor, so calling something pseudo anything is a waggy sense. But I worked up both of those patients as an intern many years later, and I was terribly impressed with how remarkably penetrating his mind was to see fundamental mechanisms in disease. In pseudo-hypoparathyroidism, there are a couple of bones in your wrist and in your hand and in your foot that are shorter. That's all the relationship between those two patients. He said it's the same disease. It took 50 years and knowledge of gene imprinting to work out how they were related. If you get the gene from the father, in your kidney, only your mother's copy of the gene is used. That's imprinting. So if the bad gene came from your father, it didn't matter because it's not used in the kidney, which is where the whole story of pathophysiology begins. But if it comes from the mother and then it's inactivated, you have the full-blown calcium deficiency disease. He didn't know that explanation, but he was just sure they were the same disease. That was very inspiring. In other words, careful observation and the ability to sort the wheat from the chaff is very important. I guess I took that. I love seeing my patients, and I've had, over the years, I don't see patients actively anymore, but I enjoyed doing it. And I remained in attending in general medicine until I turned 80, and I thought it was about time to step aside from that role, but I enjoyed it very much. The personal connection, I think, is the issue.
Well, given that, do you think you ever would have chosen a different vocation if you had to do it all over again? Would you have done something different?
Well, it's hard to say, because I think I described to you at the beginning how I sort of had this idea I would be a doctor, and so I followed it, and then things happen to you, and I didn't know I was going to go into academic medicine. I mean, I love teaching. I had a great interest in English literature. I mean, I suppose if I wasn't doing medicine, maybe I would be, like doing English literature or something, but you can't say. I mean, in other words, my whole career has been down this certain pathway, so you can hypothesize what might have happened, but I didn't have a burning alternate choice at the beginning. I didn't really know what I was doing. I just sort of followed my nose, and it all happened.
Well, we're all glad that you did. So thank you so much for joining us today.
Well,
It's
it's
been a
my
pleasure.
pleasure. You asked wonderful questions.
Thank you.